Very good evening. First of all, I thank Bhavan Morgan sir for giving this opportunity. I am a diabetes awareness and prevention committee, and I thank Anand sir and Hariharan sir for chairing this session. My topic is about food examination in the rural areas. Since the prevalence of diabetes is more than 101 people, sir, echo இருக்குதா sir?
எக்கோ அடிக்குது ரஞ்சித், கொஞ்சம் கொஞ்சம் எக்கோ வருது.
Shall I go, sir?
Yeah, you can proceed, no issues.
Yes, sir. Fine. The prevalence of diabetes is around 101 million. Actually, we have 201 million foods. The complication that was specifically in diabetic food disease more worsen, more stressful when compared to other complications like diabetic retinopathy and diabetic nephropathy. There is a rule of 15. Out of 100 diabetic patients, there are 15 patients chance of developing diabetic foot ulcer, and the 15 diabetic foot ulcer patients may develop osteomyelitis, and this may require amputation. 80% of the amputation often proceeds with a simple foot ulcer. So there is need for proper examination. We have to identify all the high-risk foot patients, and we should do at least the basic examination, which can be done within 3 minutes, followed by when to refer the patient for the surgeon or vascular surgeon or plastic surgeon. These are things I'm going to talk about. These are the high-risk group patients. Any patient with past foot ulcers or any foot deformity, patient coming with previous history of amputation or diabetic neuropathy symptoms, patient is already having diabetic retinopathy or uncontrolled blood sugars with diabetic kidney disease, and those patients already on dialysis, and patients those are wearing inappropriate shoes, sandals, high heels, and they are more prone to develop diabetic foot ulcers. Apart from that, chronic smokers and patients on alcoholic, patients already having peripheral vascular disease and obese patients also more prone to develop diabetic foot ulcer. We should assess these patients. We have to give some importance when compared to other patients so that early detection of neuropathy and prevention can be done in this group, in this stage itself. This is a simple 3 minutes examination. What we have to ask in 3 minutes is first ask questions, past history, any symptoms regarding neuropathy or vasculopathy that can be talked within 1 minute, followed by examination, inspection, palpation that also can be done within a minute, and the vascular examination and classification of diabetic foot ulcer depending upon the various classifications we can identify. First, what are the things that has to be asked about the past duration? What are the duration of diabetes? Whether the patient already had ulceration, amputation history, or patient is already having charted joints, any history for vascular, angiopathy, and smokers. Regarding neuropathic symptoms, it can be broadly divided into positive symptoms and negative symptoms. In case of positive symptoms, we have to ask for any burning feel, any pinprick sensation, and sharp shooting pain or electrical sensation that rules out positive symptoms. So regarding the negative symptoms, any numbness, pulmonary sensation, or feet feel dead has to be asked. Regarding the vascular symptoms, claudication history has to be asked whether the patient is developing pain during walk or even during rest. That has to be excluded. And chronic non-healing ulcer of more than 6 weeks has to be evaluated. Apart from that, patient already having complications with renal and renal, they have to ask the history of these complications. First, inspection. The brain doesn't know what the eye doesn't look what the brain doesn't know. So we have to look for any swelling of feet, whether the patient is having unilateral swelling or bilateral swelling. Apart from that, any change in color, erythema, or any prominent veins has to be noted. Presence of caries, fissures, dermatopathy, nail dystrophies, and interdigital fungal or mycosis has to be noted. And distribution of hair is also very important. In case of patient already having autonomic neuropathy, the patient will be having spasms, absence of sweating, and these patients are more prone to foot ulcers. Apart from these signs, we have to look for foot deformities like any clad toe, hammer toe, bunions, and hairless branches must be noted with arches has to be measured. Loss of planet has plays a vital role for development of future diabetic foot ulcer. Apart from the presence of shortcuts has to be ruled out. This is a 1 minute examination. Followed by palpation. Regarding the palpation, we had to check, we had to palpate for any bony prominence because these bony prominences are more prone to develop for callus formation, which in future may develop into osteomyelitis. And temperature difference has to be noted. For temperature difference, to note whether the patient is having cellulitis or acute sharp pains. In case of cellulitis, patient will be having high temperature and acute sharp pain also will be having high temperature. But the feature that differentiation between cellulitis and acute sharp pain is in case of acute sharp pain, ESR and CRP and other biomarkers will be normal. But in cellulitis, CRP and ESR will be elevated. And presence of pitting edema and limited joint mobility has to be evaluated. Whether the patient is having pre-existing distal involvement of joints are involved to rule out complication of specifically more prone in type 1 pneumatic matters. Regarding the peripheral pulsation type, dorsalis pedis and posterior tibial artery has to be palpated. And probe to bone tip is a very important thing that has to be evaluated to rule out chronic osteomyelitis. This can be done within 30 seconds, followed by vascular examination. Whether the color of the wound, whether the patient is having black, red, or brown, or any varicosities, varicose vein, any ulcer to rule out ischemic and arterial ulcers or venous ulcers has to be done. And capillary filling time is a very important thing that can be done with the patient. The patient is having more than 3 seconds, then the vascularity is compromised. Regarding the pulses, as I already said, dorsalis pedis artery, posterior tibial artery has to be examination, and we have to feel for the what waveform can be examined with the help of hand Doppler. Whether the patient is having triphasic waveform or monophasic waveform can be evaluated. Apart from that, a simple ankle brachial pressure index, which is the systolic blood pressure of ankle divided by systolic pressure of brachial pressure has to be aligned. The normal one is 0.9 to 1.1. If it is less than 0.5, then there is a severe vascular compromise is present, so patient has to be evaluated. And toe pressure or toe brachial index, if it is less than 7, it is normal. When it is more than 7, then there is a chance for having compromised vascularity and pulse rate. As I already said, we have to think about triphasic form, biphasic form, or monophasic form. The last one is transcutaneous pulse oxygen has to be measured over the ulcer of wound. Whether the patient is having good oxygen supply or in case of absence of oxygen supply, they are more prone to develop gangrene, even gas gangrene may be developed. These three examinations, as I said, inspection, palpation, and vascular examination can be done in our OP setting itself. Otherwise, we can teach our physician assistant and staff nurse to evaluate these signs whenever the high risk patient walk into the clinic. Apart from that, these are the warning signs, early warning signs for a diabetic patient that should not be missed. Any acute swelling of foot and ankle, whether feet goes for very cold or the legs, any color changes like reddish, blue, or blackish distinction should be evaluated. Any claudication pain, even at first, is a very early important warning sign or pain during walking. Apart from that, any presence of open sores, no matter how the size of the sores, then any chronic non-healing wounds has to be evaluated. Presence of ingrown nail, corn, callus, and lack of hair growth on the foot has to be evaluated, and proper care should be given for this patient. Since diabetic foot ulcer is the most devastating, most dreadful complication, we have to prevent this patient from developing foot ulcers. If we are going to prevent this ulcer, definitely we are going to preserve resources. I once again thank IMA, Tamil Nadu, and Balamurugan sir and Sivakumar sir for being in this wonderful opportunity. Thank you.